Normally in the heart muscle, so here's a heart muscle cell, you have a subtype of adrenergic receptor called the beta 1 adrenergic receptor. Right, so this here is a heart muscle. And the beta 1 adrenergic receptor is coupled to the G protein, and so when adrenaline binds to the receptor, that activates GS, and GS stimulates adenylyl cyclase, and that causes an increase in cyclic AMP. That in turn activates protein kinase A, and then protein kinase A phosphorylates voltage-gated calcium channels, and the result of that is to increase the probability of them opening. So stimulating what adrenaline does effectively then activates adenylyl cyclase through the receptor, cyclic AMP activates protein kinase A, and that phosphorylates these calcium channels and increases their probability of opening. So you get more calcium coming in. So the result of this is increased force of contraction, because it's the calcium which mediates the myosin and actin interaction. So you get more calcium coming in, so you get a stronger force of contraction. You also have an increase in the rate of beating. So more calcium's coming in, so you get a stronger depolarization. So that means you get more rapid beating, higher frequency of action potentials. And there are also other effects that activating beta 1 receptors does indirectly, which is also to increase the rate at which calcium is pumped into these intracellular stores. So that means in the the sarcoplasmic reticulum, you've now got more calcium packed in here. So that means that when calcium is released from here during the heartbeat, you get a bigger calcium signal. That also increases the strength. It also indirectly modulates the way the actin and the myosin interact by some unknown mechanism. So it just makes this machinery much more responsive to the calcium, and we don't really know how or why. So all these effects are the result of adrenaline signaling. And the result, the secondary result of all this is that you have decreased cardiac efficiency. And cardiac hypertrophy, which as the heart grows. I don't know why it affects cardiac hypertrophy, but it does. So these are all the effects of adrenaline, and one of the other things that can happen, so we talked about these two main effects here of having increased calcium. You might also realize that this also increases what we call automaticity. So this is the tendency of having ectopic beats. So you've got more calcium coming in, and that means that there's a danger that you're going to get enough calcium here being released to cause an extra beat to occur, partly by the fact that as calcium then gets pumped out, is done so at the expense of sodium on a 3:1 sodium to calcium ratio, and that causes depolarization, and that causes ectopic beats. So really simple, what you do here is you simply block this from happening. So what you do is you have drugs which look like adrenaline but aren't adrenaline. They look closely enough so that they'll actually bind in the binding pocket, and so adrenaline now cannot bind to it. So this is what specifically beta-1, we used to really call those beta-1 blockers, because beta-1 is the type of adrenergic receptor expressed on the heart. Just to be aware that you also have beta-2 receptors on the vasculature, and these are related to beta-1 receptors. So just to show that, this is what adrenaline looks like. You have this 6 ring here, and then a tail, a couple of hydroxyls there, and then this tail. If you then compare that with the two most common beta-1 antagonists, which you need to know about, which are atenolol, so similar kind of structure, and metoprolol. Again, you can see some of the similarities of the structure. So adrenaline, so this is adrenaline, metoprolol, and atenolol.